Usually when we talk about finding a medical answer, there's this expectation of just like pure precision, right? It feels almost like engineering.
Yeah, exactly.
Like you break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, breaking. It's clean, it's binary.
Right. And we naturally gravitate toward that kind of data. I mean, we like our health information to be visible, categorized, and, absolute.
But then you step into the world of epidemiological studies, and suddenly that x-ray machine is completely useless.
Oh, absolutely.
Because you're dealing with massive human populations, hidden variables, environmental factors, and totally flawed human memories. So to navigate that murky landscape, we are tearing into a very specific set of source material today. We're doing a deep dive on Lecture 8, focusing entirely on the validity of epidemiological studies.
It's a great topic.
It really is. We have 29 questions from the material, and our mission today is to dissect the logic behind every single correct answer so you can spot these research errors in the wild. If you want to nail the core concepts of epidemiological validity quickly and without the fluff, you are in the exact right place. We are going to read every question, every option, and explain exactly why the bolded answer is the truth.
I love that approach. I mean, epidemiological studies are essentially massive, complex searches for the truth. When you're trying to figure out if, say, a certain chemical causes cancer or if a new diet prevents heart disease, the opportunities to make a mistake are just endless.
So true.
So these questions are designed to test our ability to identify the flaws that distort that truth.
Right. But before we get into specific biases, we need to define what a good study actually looks like. I'm trying to wrap my head around the difference between precision and validity. Is validity essentially like aiming a bow and arrow?
That's a classic analogy, yeah.
Like, if precision is hitting the exact same spot over and over, even if it's, way off of the trees, validity is actually hitting the bullseye.
That is exactly how you should visualize it. You can have a highly precise study, meaning your mathematical results are incredibly consistent and repeatable every time you run the numbers.
Okay.
But if your fundamental tool is flawed, you are just precisely hitting the wrong target. Validity is the measure of whether you are hitting the actual objective truth.
Ah, got it. Well, there is a question in the material that directly tests this archery concept. Question 14, it asks, the ability of a tool to correctly measure what it is supposed to measure is called as A, precision, B, validity, C, reliability, D, consistency.
Well, based on that definition we just went over, the answer is B, validity.
Makes sense.
Right, because if the tool measures what it's actually supposed to measure, if it hits the bullseye it was aiming for, it is valid. Precision, reliability, and consistency are, they're all about repeatability, not the actual truth.
So if a tool is valid, how does that apply to the people we study? Question 1 asks, obtaining an estimate that is generalizable to relevant study population in a research study is A, external validity, B, internal validity, C, bias, D, confounding.
So the operative word in that question is generalizable.
Right.
Let's say you run a study testing a blood pressure medication on like 50 middle-aged men in a controlled lab. If you can accurately take the findings from that small specific group and apply them to the broader outside world like elderly women or younger men, your study possesses a external validity.
Oh, because it applies externally.
Exactly. It is valid externally, way beyond the immediate participants.
Okay. Question 22 hits the same concept from a slightly different angle. It asks, when the study finding is generalizable to the target population, then it is A, internally valid, B, reliable, C, accurate, D, externally valid.
Yeah, so it reinforces the exact same rule. The moment you are taking findings and applying them broadly to the target population outside the study, the answer is D, externally valid.
Wait, I'm slightly confused here. What about the inside of the study?
Good question.
Because question 11 asks, obtaining an accurate estimate of disease frequency and effective exposure on health outcomes in study population pertains to A, external validity, B, internal validity, C, bias, D, confounding. If a study is internally flawless, doesn't that automatically mean it applies externally?
Actually, no, not necessarily.
Really?
Yeah, notice how the focus in this question shifts completely away from the outside world. We are strictly talking about obtaining an accurate estimate within the specific study population.
Oh, I see.
So that means the mechanics, the measurements, and the math used on those specific 50 men we talked about are sound. The answer is B, internal validity.
That makes a lot of sense.
You absolutely must have internal validity first. If your study is internally broken, the data is just garbage, but Just because it's internally valid doesn't mean those middle-aged men represent the whole world.
Right, garbage in, garbage out. So internal validity means the arrow flies straight for the target you chose. But things can still mess up the shot. Let's look at question 7. Variability in estimation due to unknown or uncontrollable factors is A, chance, B, bias, C, confounding, D, effect modification.
The key phrase to look for here is unknown and uncontrollable.
Okay.
Because sometimes, despite rigorous internal validity, random flukes just happen. A sudden gust of wind blows your perfectly aimed arrow off course.
Right.
In epidemiology, when an estimate varies simply due to unpredictable, random fluctuations in the universe, we call that a chance.
So what if the error isn't a random gust of wind? Question 2 asks, any process that tends to produce results that depart systematically from true values in a research study is A, chance, B, bias, C, random error, D, effect modification.
This is like the critical distinction in all of epidemiology.
Okay, lay it on me.
If the error is systematic, meaning it's not a random gust of wind, but your bow sight is physically bent 2 millimeters to the left, you will consistently shoot to the left every single time. Oh, wow.
Right. That built-in consistent distortion is B, bias.
Okay, so if bias is always systematic, random flukes don't count as bias. Question 25 tests this exact boundary. It asks, which of the following is not a systematic error in an epidemiological study? A, random error, B, confounding, C, selection bias, D, information bias.
Well, since systematic error means a consistent, predictable distortion of the data, the one option that defies that definition is the unpredictable one.
Makes sense.
Therefore, the one that is not a systematic error is A, random error, because random error is just chance.
Which brings us to a fundamental rule of how bias behaves. Question 15 states, bias may distort the association between exposure and outcome among the study participants. A, true, B, false.
This is unequivocally A, true. I mean, that is the literal function of bias. It warps the mathematical relationship between what people were exposed to and what health outcome they experience, pulling the entire study away from the truth. Okay, that sets up section 2 perfectly. We know bias is a systematic error, so let's look at the first major threat, which is selection bias. This is all about how we pick the people for our study. If your starting line is uneven, the whole race is compromised.
Exactly.
So question 3 asks, systematic selection of more number of exposed participants with a higher risk of outcome in a cohort study will result in A, selection bias, B, information bias, C, confounding, D, random error.
Just look at the mechanism of the error here. The researcher is systematically stacking the deck, basically, by bringing in exposed people who already have a higher baseline risk of the disease.
Right.
Because the flaw happens at the exact moment of choosing the participants, it results directly in a selection bias.
Let's see how that happens in the real world. Question 16 is a very specific scenario. A case control study was conducted to know the effect of smoking on lung cancer among hospitalized patients. The controls were recruited from patients admitted to the respiratory ward for other conditions. What type of bias will be introduced? A, selection bias, B, information bias, C, confounding, D, random error. I mean, why on earth would a researcher pick controls from a respiratory ward?
Honestly. It usually happens out of convenience.
Really?
Yeah, the researcher is already in the hospital looking at lung cancer patients, so they just walk down the hall to the general respiratory ward to find people without lung cancer to act as their healthy comparison group.
But people in a respiratory ward aren't healthy.
Exactly. They are in there for emphysema, severe asthma, chronic bronchitis conditions heavily linked to smoking.
Oh, right.
If you compare lung cancer patients to a control group that already has an artificially massive rate of smoking, the difference between the two groups shrinks. You end up concluding that smoking isn't that bad for you entirely because you selected a distorted control group. You've introduced severe selection bias.
Wow. You essentially rigged the game without realizing it.
Yep.
Question 23 broadens this concept. Which of the following can introduce selection bias in a case control study?
Yeah.
A, differential recall about exposure by the cases. B, collecting data differently from the exposed and unexposed. C, inclusion of controls not representative of the target population. D, systematic distortion of the truth by the study participants.
So this echoes the exact same respiratory ward mistake. If your control group doesn't accurately mirror the general healthy target population you are drawing from, your internal validity is ruined before you even collect a single data point.
Okay.
So the action that introduces this is C, inclusion of controls not representative of the target population.
So how do you avoid rigging it? Question 10 asks, to reduce selection bias in case control studies, all of the following are true, except FT. A. Use population-based design,
Sure.
apply different eligibility criteria for selecting cases and controls. C. Both cases and controls undergo the same diagnostic procedures. D. Avoid hospital-based design. I have to challenge option B here. Cases have the disease and controls don't. Don't they inherently require different criteria?
That's a really common point of confusion. They have different health statuses, yes. But the eligibility criteria to enter the study, things like age range, geographic location, or socioeconomic bracket, those must be identical.
Oh, I get it.
Yeah, if you only accept cases who are males over 50, but your controls are randomly selected college students, your data is completely useless. Having different rules for who is allowed in the door creates bias. Therefore, the thing you should not do, the exception, is B. Apply different eligibility criteria for selecting cases and controls.
Okay, moving into Section 3, information bias. So, we've carefully selected the right people using the exact same criteria. But what if our tools for measuring them are broken? Let's look at human memory. Question 13. Better recall of exposure only among the cases in a case control study can result in A. Information bias, B. Confounding, C. Investigator bias, D. Selection bias.
This relies on a psychological phenomenon called recall bias.
Interesting.
Imagine asking someone recently diagnosed with severe lung cancer to detail everything they inhaled 20 years ago. That patient has spent weeks agonizing over their past, searching for a reason they got sick.
Yeah.
Their memory is hyper-focused.
Right, they've been obsessing over it.
Exactly. Now ask a perfectly healthy control the same question. They won't remember, and frankly, they won't care. Because the information being collected is systematically different based entirely on the uneven effort of memory, it results in an information bias.
Human memory is terrifyingly unreliable. But sometimes it's like an active deception. Question 19. Systematic distortion of the truth by study subjects is called as A. Plagiarism, B. Chance, C. Confounding, D. Prevarication. Why wouldn't they just call this lying?
Well, in epidemiology, we have to account for social desirability.
What do you mean?
People routinely underreport how much alcohol they drink, or they overreport how much they exercise because they want to look good to the researcher. It's a systematic distortion, not just a random mistake.
Right.
The technical vocabulary word for this behavior is D, prevarication. Researchers actually have to design surveys with overlapping, redundant questions just to catch people prevaricating.
That's wild. But investigators aren't immune to distorting the truth either, right?
Sure.
Question 28 asks, systematic collection of data by an investigator supporting an expected conclusion in an epidemiological study may result in A. Confounding, B. Information bias, C. Selection bias, D. Random error.
Yeah, and it's rarely like a cartoon villain scientist faking numbers. Usually it's incredibly subtle.
Like a
An investigator studying a new arthritis drug might subconsciously push the treatment group to report positive improvements, while quickly dismissing a minor complaint from the control group. Because the investigator is changing the way data is recorded based on their own expectations, this falls firmly under B, information bias.
which explains how to fix it in question 24. Which of the following is true about information bias in a cohort study? A. It is caused by higher attrition rate among the exposed group. B. It can be caused by selecting controls from the community. C. It can be avoided by uniform outcome ascertainment. D. It can be minimized by reducing loss to follow-up.
So the options try to trick you with selection bias terms like attrition and loss to follow up. But if information bias comes from measuring two groups differently, the true statement is C. It can be avoided by uniform outcome ascertainment.
Let's translate that terminology for a second. Uniform outcome ascertainment is essentially a highly technical way of saying measure everyone with the exact same yardstick.
Yes, exactly. Every single participant gets the exact same blood test at the exact same time of day, processed by the exact same lab. Uniformity completely removes the investigator's subtle influence.
What if we just get a massive amount of people for this study? Question 6. All are true regarding measures to reduce information bias, except T. A. Precise operational definitions of all variables. B. Detailed measurement protocols. C. Adequate sample size. D. Training, certification, and recertification of data collectors.
Think about the broken yardstick we just mentioned. If your yardstick is missing an inch, measuring 10,000 people instead of 100 people doesn't fix the yardstick.
Right, you're just wrong 10,000 times.
Exactly. It just gives you 10,000 completely biased measurements. Increasing your sample size only reduces the random gusts of wind chance. It does absolutely nothing to fix a systematic error. So the exception, the one that does not reduce information bias, is C, adequate sample size.
You cannot outsample a bad tool. Question 12 deals with investigator influence. Blinding in an epidemiological study is a way to deal with A, chance, B, selection bias, C, information bias, D, sampling error.
So blinding means the doctor handing over the pill doesn't know if it's the real drug or a sugar pill, and the patient doesn't know either.
Right, double blind.
Exactly. If the investigator doesn't know who is in which group, they can't unconsciously push for their expected conclusion. It removes their subjective influence, making it a direct countermeasure against C, information bias.
Awesome. Let's move to section 4. We are tackling the absolute villain of epidemiology now, confounding. Question 4 sets the definition. The effect of the exposure of interest on the outcome is distorted because of the effect of extraneous factors that are related to both the exposure and outcome. This phenomenon is called A, correlation effect, B, confounding, C, recall bias, D, measurement error.
This is the ultimate third wheel scenario. You think A causes B, but there's a hidden C in the background manipulating both of them, confusing the entire relationship. That phenomenon is B, confounding.
Let's look at the most famous real-world example of this. Question 17. A researcher studied the effect of coffee drinking on myocardial infarction. The effect of coffee drinking on myocardial infarction was distorted because of the presence of a third factor, i.e. smoking. This phenomena is called as A, correlation effect, B, confounding, C, recall bias, D, measurement error.
Yeah, for decades, early studies showed that people who drank a lot of coffee had drastically higher rates of heart attacks or myocardial infarctions.
Which sounds terrifying.
It does. But researchers eventually noticed a behavioral link. Heavy coffee drinkers in the 70s and 80s were also heavy cigarette smokers. When researchers separated the data looking only at non-smoking coffee drinkers, the risk of heart attacks vanished entirely.
Wow.
The coffee was innocent. Smoking was the true culprit, but it was hiding in the data tied to the coffee habit. Because smoking is the third variable distorting the truth, this is a textbook example of B, confounding.
Confounding is just incredibly tricky. Question 8 states, all are true regarding confounding in an epidemiological study, except A, may simulate an association that does not exist, B, may increase or decrease the strength of association, C, may not reveal an association that does exist, D, always change the direction of effect.
Confounding is deeply mischievous. It can conjure a fake association out of thin air, like the coffee example. It can hide a real association, making a dangerous drug look safe.
Right.
And while it can sometimes flip the direction of an effect, making a harmful exposure look protective, it does not do that every single time. Therefore, the false statement is D, always change the direction of effect.
Okay, question 27 hits this mechanism from another angle. Which of the following is false about confounding in epidemiological studies?
Yeah.
Confounding may simulate an association when it does not exist. B. Confounding does not increase or decrease the strength of the association. C. Confounding may hide an association that exists. D. Confounding may change the direction of an exposure-outcome association.
Well, we just established that confounding absolutely plays with the strength of the data. It can make a weak link look massive or a massive link look weak.
Exactly.
So the overtly false statement here is B. Confounding does not increase or decrease the strength of the association.
Now, I want to push back on question 20 because the wording is very specific. It asks, crude association in the presence of a confounder is the actual causal association. A, true, B, false. Wait, if the data literally shows a mathematical link between coffee and heart attacks, isn't that the actual association? Why is it false?
Because of what the word crude means in statistics.
Okay.
A crude association is your raw, unadjusted data. It's the numbers before you've done any critical thinking. If you know there is a confounder hiding in that raw data, if you know the smoking variable is tangled up in the coffee variable, then your crude data is actively lying to you.
Oh, I see.
It cannot be the actual biological cause. You have to mathematically strip away the confounder to find the truth, so the statement is strictly B, false.
Which brings us to the final stretch, section 5, the solutions. How do researchers fight back against these errors? Question 5 asks, biases can occur during which stage of research study? A, study design, B, study implementation, C, data analysis, D, at any of the above stages.
This requires eternal vigilance. You can rig the game, picking participants at the design stage. You can use a broken thermometer during implementation, or you can crunch the numbers with a bias during analysis.
So it's everywhere.
The threat never stops, so errors can happen D, at any of the above stages.
So how do we stop the third wheel before the study even gets off the ground? Question 18. Which of the following method is used to address for known confounders at the designing stage of a study? A, matching, B, regression, C, stratification, D, adjusted analysis.
Notice it specifies the designing stage. You haven't collected data yet. If you know age is a massive confounder for heart disease, you can actively intervene while picking people.
Like,
For every 50-year-old you put in the exposure group, you deliberately recruit a 50-year-old for the control group. You pair them up perfectly. So age is identical across the board. That active pairing is a matching.
but what if there are variables we don't even know exist? Question 21 asks, which of the following is the best method of ensuring that the experimental and control arms in an experimental study are similar with regard to known and unknown confounders at the planning stage? A, matching, B, randomization, C, stratification, D, multivariate analysis.
This is exactly why double-blind randomized clinical trials are the absolute gold standard in medicine. You can't match for a genetic marker you haven't discovered yet.
Right.
But if you take 1,000 people and literally flip a coin to decide who gets the drug and who gets the placebo, the fundamental laws of probability state that any hidden unknown confounders will be evenly split between the two groups. The only tool that destroys unknown confounders is B, randomization.
But epidemiology isn't always an experimental trial. Sometimes we just observe what people are already doing. What if we've already collected the data and we find a confounder? Question 9. The method which can use to alleviate confounding during data analysis in an epidemiological study is A, multivariate analysis, B, restriction, C, matching, D, randomization.
Well, if the data is already sitting on your desk, you can't go back and match people, and you can't randomize them. You are stuck at your computer.
Okay, so what do you do?
You have to use complex, computer-driven mathematical equations to untangle the variables, adjusting the numbers to isolate the exposure from the confounder. That mathematical approach is A, multivariate analysis.
Let's test that logic with question 29. Which of the following is not a method of dealing with confounding during the design stage? The specific options actually got cut off in our source text, but conceptually, how do we solve this?
Whenever you get a multiple choice question like this, ask yourself, am I doing this with people or am I doing this with math? Dealing with confounding at the design stage involves people.
Right, like the matching we talked about.
Exactly. Or you use restriction, refusing to let anyone who smokes into the study, or you use randomization. If you see an option like stratification or multivariate analysis, which are purely mathematical adjustments applied to a spreadsheet, those are analysis stage tools. So any mathematical adjustment is the correct answer for what is not a design stage method.
Finally, question 26 brings it all together. Which of the following measure is related to ensuring the internal validity of a study? A, valid and reliable measurements of exposures and outcomes. B, including an adequate number of study participants. C, complying strictly with the study protocol. D, all the above.
Internal validity is an entire ecosystem of rigor. You need perfect measuring tools to avoid information bias. You need adequate sample sizes to defeat random chance. And you need strict adherence to protocols so investigators don't prevaricate.
So it's everything.
It requires all of these defenses working together, so the answer is definitely D, all the above.
Awesome. 29 questions down. If you were preparing for your exam, you just navigated the entire minefield of validity. You know how to spot an uneven starting line in selection bias, how to recognize broken yardsticks in information bias, and how to untangle the sneaky third wheel of confounding.
It's totally crucial to master these concepts, but I want to leave you with one final thought about the limits of our tools. We just discussed how we use multivariate math to fix the confounders we know about and randomization to neutralize the ones we don't. But randomization is only possible in an experimental trial where we control the exposure.
Right, like a son who actually takes a pill.
Exactly. But what happens when the exposure is something we can't ethically or practically randomize? We can't force 1,000 people to smoke cigarettes for 10 years just to see what happens.
Oh, wow. Yeah, that would be highly unethical.
Right. We have to rely on observational data, which means we can never use randomization. If we can't randomize and there is a massive unknown confounder buried in the population's behavior that we haven't even discovered yet, how do we ever truly isolate the cause?
That implies there might be associations we currently accept as medical fact that are actually just hiding a massive, undiscovered third variable.
It is the ultimate limit of observational epidemiology. We can design the perfect study, eliminate all known biases, and still be totally at the mercy of the unknown unknowns.
Wow. Well, keep aiming for the bullseye, question the hidden variables in your data, and we will catch you on the next deep dive. Best of luck on your exams.